Hi, my name is Mio Nakamura, and I'm a dermatologist from the University of Michigan. Today, I'm going to be talking about psoriasis and its impact on mental health. So we're going to start with the case today. So this is a 20-year-old male who comes to your practice with a 1-year history of a rash affecting the scalp, trunk, extremities, and genitals. He also reports pain in his hands, worst in the morning, and he's only been prescribed very small tubes of topical steroids when he's gone to the emergency room. He provides only short answers to your questions, and he avoids eye contact and is antsy. When you examine his skin, he's kind of hesitant to show all of his skin, but you see psoriasis on the scalp, the trunk, extremities, genitals, and even the nails. And when you examine his joints, you find dactylitis on multiple fingers. You do a PASI, the Psoriasis Area Severity Index, and it shows 15.3, which is quite severe. His body surface area involvement is 30%, so he definitely has severe psoriasis. With that and his overall demeanor and affect, you wonder how he's feeling in terms of his mental health. So you have him complete a couple of questionnaires. The first one is the Dermatology Life Quality Index, or DLQI. He scores a 15 on this, which is a very large effect, negative effect on quality of life. You also have him complete the Patient Health Questionnaire, PHQ-9, and he scores a 14 on this, which translates to moderate depression. So things like this are not uncommon in patients with psoriasis. So depression is seen in approximately 20% of patients with psoriasis compared to 4% of the general population. Psoriasis patients have been found to be at 2 times greater risk of developing depression compared to the general population. And this is after controlling for confounding variables such as sex, age, race, body mass index, level of physical activity, history of smoking, alcohol use, and other major medical problems like heart disease, stroke, and diabetes. And furthermore, in these patients with depression, suicidal ideation or suicidal behavior is very common, seen in up to half of patients with psoriasis with depression. So this is a major issue. And this is something that's been known for some time now. This is a study that was done back in 1999, where investigators gave out a questionnaire called the SF-36. The SF-36 is a questionnaire that assesses multiple aspects of quality of life and compared psoriasis patients' scores to patients with other major medical problems like high blood pressure, cardiovascular disease, heart failure, diabetes, as well as depression. And they found that patients with psoriasis have just as much disability as patients with other major medical illnesses. Psoriasis is also unique because not only does it affect, your day-to-day, it also affects very specific aspects of life. So in this study, the investigators looked at how intimacy is affected by psoriasis. And so they gave out surveys and showed that multiple aspects of intimacy are negatively impacted by psoriasis, especially if you have more than mild psoriasis. So, for example, psoriasis patients are experiencing fear of rejection. They're trying to conceal their skin from others. They're worried about what their partners see. They feel like their emotional connectivity is burdened by psoriasis and all these other factors as well. So psoriasis definitely impacts many aspects of one's life negatively. There are certain risk factors that increase psoriasis patients' risk of developing depression. For example, female gender, younger age, more severe psoriasis, bothersome symptoms like itching or pain, palmoplantar, genital, or nail psoriasis. So some of these special areas that are involved, as well as psoriatic arthritis. And so in our patient from the case before, he has multiple of these risk factors. So he's younger, his psoriasis is quite severe, he has general and nail involvement, and you did see signs of psoriatic arthritis. So he has multiple risk factors for developing depression. It's definitely a complex psoriasis and depression. There's definitely a complex interplay, but it's a vicious circle. So stress, as we know, can cause new onset or worsening of existing psoriasis. And psoriasis then will impact your quality of life in terms of social interactions and intimacy, work productivity, and overall mental health. That adds just stress, and then that creates a worsening psoriasis. So it kind of goes round and round, unfortunately. And it's really important to break this cycle. Before we talk about that, I just want to note that there is systemic inflammation that's seen in depression that may be associated with that of psoriasis as well. So there are several inflammatory gene expression and markers that are elevated in depression, such as toll-like receptors, C-reactive protein, TNF-alpha, and IL-6. And when depression is treated, the levels of these inflammatory markers actually normalize. So I want to look at IL-6 and focus a little bit more on that first. So IL-6 is an interesting cytokine. In depression, it affects neurotransmitters, so specifically tryptophan metabolism. And so certain metabolites of tryptophan can have neurotoxic effects and are increased in depression. IL-6 also affects the HPA axis and actually hyperactivates it, and this can be seen in depression as well. IL-6 is a really important mediator of the immune system. Usually when it's present, it will block T regulatory cells, and T regulatory cells are very important in terms of keeping your inflammation in check. So when Tregs are not working properly or are blocked, then you have these pro-inflammatory pathways such as Th17 and Th1. And so IL-6 has been shown to exert these pro-inflammatory effects in a range of organ systems, and it has been implicated in a variety of diseases like psoriasis, depression, cancer, heart disease, and rheumatoid arthritis. So the big question is, does treatment improve mental health? There have been a number of studies done on this, but I want to highlight the specific prospective study. So in this study, there were the investigators enrolled adult patients with psoriasis, severe psoriasis involving at least 10% of the body surface area. And these patients were treated with adalimumab or ustekinumab for 6 to 9 months. And the investigator measured PASI, which is psoriasis severity, as well as the psychological status of these patients using an index called the Psychological General Wellbeing Index. So this is showing the baseline PGWB score. So you can see that psoriasis patients have a score that's as low, potentially if not lower, than patients with these other major medical conditions like heart failure, coronary artery disease, diabetes, and even breast cancer. This is showing the improvement or change in PGWB over the course of 24 to 36 weeks on adalimumab and ustekinumab treatment. So you can see the slight increase in PGWB, which is showing an improvement in the quality of life. You can see the improvement better in this graph where we're showing the pre-treatment PGWB score and then the post-treatment PGWB score. So you can see that these scores are much improved after treatment, and these scores are actually comparable to the general healthy population. So essentially, treatment of psoriasis can improve quality of life and depression symptoms. And this is seen specifically with biologic agents. And this is likely due to, improved quality of life, but also likely decreased systemic inflammation as well. And studies have shown that treating depression along with psoriasis can have additional benefits compared to treating just psoriasis. So referring patients for psychotherapy, cognitive behavioral therapy, relaxation training, meditation, things like that can be additionally helpful to improve the quality of life of patients with psoriasis. Going back to our case presentation, so the patient was started on risankizumab, which you all know is a biologic, and we did offer mental health referral, but the patient declined. We decided to see them back in 4 months. And at that visit, he was a lot more interactive. He was making eye contact. He was more talkative. He was wearing clothes that showed his skin. His PASI was 1.7. His BSA was down to 3% from 30. His DLQI was only 7, and his PHQ was 2. And so very small negative effect on quality of life at this point and minimal depression. And, this score signifies that there's no treatment necessarily needed for depression for him at this time. And so, what should the clinician take away from all this information? So, it's definitely important to screen psoriasis patients for depression. So, one thing you can do is identify risk factors for depression. So, we mentioned some of them earlier. So, the younger age, the female gender, severe psoriasis, involvement of special sites, presence of psoriatic arthritis. These are all risk factors. And sometimes if you do have that systemic inflammation of psoriasis, that can increase your risk of developing depression as well as other comorbidities like psoriatic arthritis, cardiovascular disease, metabolic syndrome, diabetes. So kind of looking at the patient holistically and looking at the presence of overall comorbidities may be helpful to identify patients who may also have depression. You want to treat these psoriasis patients adequately in a timely manner. It's important to, if the patient is open to it, offer multidisciplinary care with mental health professionals. And then you want to reassess mental health status at subsequent visits. So here are some tools for the clinical setting that you can consider using to assess patients' mental health. So the first two are suicide scales. So these are asking about suicidal ideation and behavior. The CSSRS is often used in clinical trials and can be helpful to identify like new onset suicidal ideations or intent. The PHQ-2 and 9 are widely used not just in dermatology, but across the medical field. It's a very quick questionnaire that patients can fill out very easily and assesses for depression. So that one is a good one. The HADS is a little more involved, but definitely can be helpful, can be used in a lot of clinical trials as well to measure the severity of depression as well as anxiety in patients with different medical conditions. If you're looking for more of a skin-specific quality of life measurement, then DLQI is the one to use, also used oftentimes in dermatology clinical trials. It's only 10 questions, and it really touches on a lot of important aspects of life, such as how the skin condition is affecting your daily life, leisure, work, relationships, and treatment. So these are all things that you could consider using in the clinical setting as a quick assessment of a patient's quality of life, impact, or presence of mental health conditions. So, in conclusion, depression is prevalent in psoriasis patients, and this is likely because of the negative impact on quality of life when you have psoriasis, as well as the stress it causes, and it's this vicious circle. There is definitely a systemic inflammatory component that's shared between psoriasis and depression, as well as other comorbidities. And so it's really important to treat the psoriasis adequately, which will in turn improve the depression and the systemic inflammation as well. And so, and then remembering to incorporate screening and multidisciplinary care. These things are key to the holistic approach to treating a psoriasis patient. Thank you so much for your time. And I hope you enjoyed the talk. Thank you.